All right, so questions for lecture number 2. This was created by Abby Berry. Abby Berry is one of my students who is quite phenomenal. She's about to graduate. She's done, but she's always been that student who works really, really hard to do extra things for everybody around and never says a word about it. Never tries to take the lead. When she gets the lead, she's hesitant to get the lead because she doesn't want anyone to know how much she's getting the lead, because she doesn't want anyone to look at her differently, because she doesn't see herself as any different. But everybody else does. She sticks out like a sore thumb, even though she keeps her head to the ground and literally watches her feet when she walks, so that she can be that unnoticed by every individual in this entire earth. Unfortunately, when she walks, I had a friend who once told me, when you walk, it's like there is golden glitter everywhere around. It's like a disco ball, and that is what Abby Berry is. And she never says a word, ever. She never asks for anything, ever. She's always baking stuff for everybody, always, because she wants human interaction that much, and she never wants a single accolade for it. She reminds me of somebody I know that is quite a phenomenal person when you really kick back and look at it, and that person is me. And I don't usually say good things about myself, but I feel like if I'm going to sit here and talk about her being like me, I have to acknowledge that maybe there is something great about me, or maybe there is greatness within me, right? Because that's all I ever tell you guys. This cat, though, be proud of her. If you see her, tell her how wonderful she is. I got a lot of you guys who I just think are absolutely fantastic. And I'm not going to start yelling names, because if I do and then I miss somebody, it's going to disappoint. But this gal right here and a other group of my gals in this class, and some of my gentlemen, they are the students that nobody watches, because everyone knows that they're doing fine. And they need love too, because the mamas are always worried about the wrong ones when we should be saying, hey, good job to the right ones. And they get a lot of flack for that, for being the good kid. So this one in particular, she's going to be one of those legend nurses. And I'd also dare to say she's probably going to be an educator if she's smart. So let's go to the next slide. Now that I've talked about Abby Berry for 2 minutes and 21 seconds, I'm so proud of you and I love you, kiddo. And I'm going to miss you. Next slide. All right, let's see if I can figure this one out. So an IV antibiotic is prescribed for a client with post-operative infection. All right, the medication is to be administered in 4 divided doses. So that it would be Q. Why can't I make a Q? Q, or a square, whatever. Q 6 hours. As 6 times 4 is 24 hours in a day. So what is the best schedule for administering this prescription? All right, cool. So sometimes you'll get questions like these, which are what I call freebies. All right, given equally divided doses during waking hours. Well, Jesus, when does someone sleep and when does someone wake? No, go away. Administer with meals and a bedtime snack. Again, no. When we're talking about 4 divided doses, means 4 divided doses. Are you going to sit down at those times on the dot? Probably not. That's dumb. All right, this one is 8, 12, 4, and 8 again. No, that's every 4 hours. So that is Q4 hours, which looks like 94 hours, but whatever. And then 10, 4, 10, and 4. Yeah, that's right. That's every 6. Yep. So that's the answer. Final answer. And let's go to the next slide. And yep, all done. Let's go to the next one. I haven't realized how much neuro is in here, but there's a lot of neuro. So let's do this one. The mother of a child with cerebral palsy asked the nurse if her child's impaired movements will worsen as the child grows. Which response provides the best explanation? Well, let's talk about cerebral palsy for a second, because I'm sure you guys are going to have a chance to listen to it, and it's put in here often enough that we probably need to get into it. So cerebral palsy is like a group of disorders that affects a person's ability to move and maintain balance and posture, right? So the most basic ability to have a normal gait. It's the most common motor disorder, or motor disability in children, I believe. Usually it has to do with brain damage. So either there was complications during birth and the patient had, a moment of hypoxia or asphyxiation. Maybe there was a cord wrapped around the neck, that type of a deal. Maybe there was abuse or trauma in early childhood, but this is usually a problem in the development sector of this. And once the damage is done, the damage is done. Now, the way that the patient responds to that damage, it varies from patient to patient. There's a lot of other factors. Environmental things come into play. Are the parents good? Are they nurturing? Do they try to, do what they can, or do they just kind of keep them to the side and pretend like they're not there because, they have a significant disability, but they're probably not really there. That type of a deal. You guys know what I'm talking about. So we have to look at all of these things and make sure, because they all come into play. So let's see what our options are. Continued development of brain lesion determines the child's outcome. No, this has to do with the lack of oxygen and then the brain not being supplied enough oxygen to sustain. So what the brain does is, in order to save the brain, okay, I want you to think about, this is a terrible thought, but here we go. You are in, I don't know, quicksand, and you are going down the quicksand, and all that's left is the very tip of the iceberg, right? Just your lips. So you're like hanging on and you're pursing your lips to just take another gasp of air. All right, so as that's happening, you're starting at your feet, and your feet are starting to shut down systematically, right? So it shuts down all the things that it doesn't need necessarily. So during this time of this lack of oxygen in the brain goes, all right, let go of the legs. And that's why this person has this deficiency, because between that or the heart, it's going to choose to let go of the legs. Well, oxygen came back to the patient. The patient was fine and stabilized, but the damage was already done to the legs. It's that type of a deal. Does that make sense? A lot of people think that this is like a demyelination thing, and that's not. That's multiple sclerosis. Don't get it mixed up. It makes a big difference in the world. And then sometimes they get this mixed up with like muscular dystrophy. That's a whole nother game. All right. Versus other lung disorders that are reminiscent of the same symptoms. So just be really careful that you understand this, and specifically cerebral palsy. Brain damage with CP is not progressive. That's accurate, but it does have variable course. See, I just said that. Okay, cool. There's that. All right, so cerebral palsy is one of the most common permanent physical disabilities in children. No. What? No. I would certainly hope that all these babies don't rando have all of these terrible things that happen to them very, very early in life. No, that's terrible. Severe motor dysfunction determines the extent of successful habitation or habilitation. Severe motor dysfunction determines the extent of successful habilitation. I don't even know what that's saying, if I'm honest. Severe motor dysfunction determines. What about severity of motor dysfunction determines the extent of successful habilitation? No, because if they have severe motor dysfunction, they wouldn't be able to be habilitated. No, I just hate that whole. No, I just hate it. Okay, I'm going to go with B, final answer. Next slide. All right, cool. And again, we find that the answer is B. Let's just go to the next slide. All right, the nurse is preparing a teaching plan for an older female client diagnosed with osteoporosis. All right, without looking down, without seeing this question. Osteoporosis. Bone density sucks, right? We probably have a breakdown, and we are much shorter, and we're probably have an abnormal gait when I see osteoporosis. So the first thing I think is false and safety, and vitamin B or vitamin D deficiency, and breaking a hip. These are all the things that come to my brain already. Which expected outcome has the highest priority for the client? Okay, so we're going to find one of these. And again, I'm not looking down. I need for you to know I'm doing this in real time, whatever that looks like, which is why you always hear the kids crashing and screaming in the background, because I want you to know that I'm in this with you, right? Like, we're figuring this out together. Because what I'm doing is I'm actually, I don't really tell you what I'm doing, but what I'm doing is I'm walking you in a line. I'm walking you in a line. We'll put it that way. I'm walking you in a specific line for a specific reason. And then once we get through the end of this lecture, I'll tell you what I was doing. So which expected outcome has the highest priority? Identifies 2 treatments for constipation due to immobility. No, she's got osteoporosis. She didn't say she was immobile. It didn't, if it's not there, don't, like, I know they say, forget to be nurses, and if it's not in there, it didn't happen. I mean, listen, I need for you to forget to be nurses, because you got to remember, this is for the bottom line nurse. This is for the student who's never been a nurse a day in their life. So I don't need for you to forget to be a nurse. I need for you to forget how to be smart. I need for you to remember that this is 5th grade in coloring books. This is for the bottom line nurse in the U.S. So if you look at all of the nurses in the entire world, and you look at the worst nurse that is licensed, all you have to do is slightly above that. Like, I don't mean to be funny, haha. But we always go, you're going to get 85 questions, and that's all you're going to get because you are a brilliant, smart nurse. Dude, I don't care if it takes you 130. I don't care if it takes you the whole blunt of the whole deal. The bottom line, and they're like, well, we want high-grade nurses. We don't want these types of people taking care of us. Okay, cool. Go to nursing school and shut up. Because here's the deal. You got 2 options. You can either respect us and respect our craft and give us respect that we're willing to do the things that you guys wish you had the gall to do. Wish you had the guts to swallow what we do. So don't come at me like that, bro. Like, don't do it. Don't come at me like that, bro. Don't do it. That's stupid. That's so stupid. 2, if you got the nerve to tell me how to do my craft, why don't you get up out of that hospital bed and tell me what I need to do about it and how I need to do it? I heard like 3 of you go, oop. But you know what? That's the deal. Is we are so caught up in watching people and judging people because things are always online. Information is always being fed to us, but someone's got it better, and someone's got it better than that. When that's figured out, you know, some rando comes up with some death-defying way of fixing this stuff that ends up killing people. Because we're just being stupid. We're focused on judging people by every little thing that they say and do. Oh, well, they said this, and that means that. I'm going to need for you to quit analyzing me. I'm going to need for you to just treat me like a human being. I'm your friend. I'm not someone on social media trying to have a pageantry going on here. I'm trying to educate you. All right? Don't be like this. Don't do it. Don't do it. So, name 3 home safety hazards to be removed immediately. Yeah, remember we just talked about this? Talking about osteoporosis. These are the things we have to worry about with these kids. These kiddos and cadets. So, let's look at C. States 4 risk factors for the development of osteoporosis. She going to nursing school? No. All right, list 5 calcium-rich foods to be added to her daily diet. It's too late for that. Like, we need to do something more. Her supplement isn't going to be enough. Not in this state. So we gotta take tablets. We gotta do gel tabs. We gotta do injections, things of that nature. She needs like 10,000 units a week, if I'm not mistaken, or maybe it's daily. I'll have to look at it again. But it's a ridiculous amount for someone with osteoporosis. 10,000 keeps coming to my brain. I'm pretty sure it's 10,000 is a dose. And I want to say it's every 3 days. But again, there's variables. Some doctors want to do it, more frequently with a smaller dose. Some people want to do it just one injection every couple of weeks. It's variable. But what we need to always pay attention to is safety. And safety is going to be that bottom line nurse I talked about. And when you think you know that bottom line nurse, I want you to think about that nurse that you were just like, that is the laziest nurse I've ever met. I need for you to know the bottom line nurse isn't her. She's probably about midway. I'm dead serious. Just keep these things in mind. Don't let this test freak you out so much. If you go in thinking it's a giant, it's going to stomp you like a giant. But if you say, hey, your foot ain't that big, it all of a sudden gets smaller. Right? Look at this as the it clown, right? If you're not afraid of it, it dies. Let that be what you treat this test as, right? Just an illusion. Because dreams, much like failures and fears, are nothing more short of an illusion you create within yourself, and that's it. So you have the power to change that illusion and create that reality within it, if that makes any sense. All right, let's go to the next slide. All right, cool. Looks like we did good there. Let's go to the next slide, please. All right, client is recovering in the outpatient surgical unit after an endoscopic carpal tunnel release. Cool, let's do that. Nurse assesses the client's vital signs, pain level, and dressing. So we've done everything we need to do. Before discharging the client, so we're walking out the door, which intervention should the nurse implement? Administer a No, you wouldn't give an NSAID right before you're walking out the door. That's dumb. No, because they should already have whatever meds they need. No, that's not it. Check the neurovascular status of the distal digits. Yep, that's it. Here's the deal. The last thing a nurse is going to have to do is confirm that that patient is stable walking out of that door. Part of it's going to be distal digit checks. Period. You just had surgery on an area that if it's too tight, it could cause neurovascular degeneration and hypoxia of that area, and then eventually necrosis, or other problems in between all of those things. So no, you're not playing with that. That's your answer right there. Change dressing if drainage increases. No, it's gonna. Can they not change it themselves? Presumably you've already given them that education. And again, let me point out, can you elaborate? If drainage increases, to what? Right? We can't presume, to what degree? Position the arm in a sling for discharge. I don't even know that that's a thing, if I'm honest. It might, it sounds like it could be a thing. But again, I'm not well versed in ortho. This is where I'm not so cool. Right? If that's even ortho that does it, it could be somebody else for all I know. So I'm going to go with B, final answer. And using the idea of passive versus active, because we're positioning an arm in a sling, we're changing the dressing, but here we're checking for something that's going to be of vital status to us, life, limb, or eyesight. So that's one of these things, and that's the passive versus active as well. Let's go to the next slide and see if we're right. Yeah, that's it. That's it for sure. All right, let's do the next one. All right, an older client is admitted in respiratory distress. That sucks. Oh, secondary to heart failure? That really sucks. I don't know what it is. If I can't breathe, that's already bad enough. But if I can't breathe and I'm drowning in my own fluids, oh boy. It's like you're slowly dying Titanic style on the inside. No, I'm good. I'm good. I'm good. I don't know what it is. You add in heart failure and all of a sudden I just get bad. Coronary artery disease. Yeah, no dip. Hypertension. Yeah. Again, the aforementioned. And AFib. Shocker. Truly a shocker. So now we're a stroke risk increase as well. Which nursing problems should the nurse include in the client's plan of care? Whew. All right, cool. Fluid volume excess. Yeah. Respiratory distress secondary to heart failure. Ta-ting! I can hear them bubbling in the hallway from their hospital room. Decreased cardiac output. Yeah. That's why they call it heart failure, not heart, I don't know, sailor. I didn't have anything else that worked. It was supposed to be a positive word. I'm trying to make up for it. Now I'm getting panicky and I just don't even know anymore. It's not going to happen. It really isn't going to happen. Okay, I'm done. I'm done thinking about it. I was going to say something quippy and then it just went out the window. Altered peripheral tissue perfusion. Well, yeah, you would have altered peripheral tissue perfusion. You guys say it. Altered peripheral tissue perfusion. You would, because again, you're not getting that tissue perfusion because you have your cardiac system is only going to save so much, so it's going to save what's important, and that's why you got cold tissue. That's why you got cold this and that. Fluid volume deficit. No, you would not have a fluid volume deficit. You would have a fluid volume overload. And fatigue. Yeah, you'd be huffing and puffing and blowing the house down trying to walk down the room. Yeah, so A, B, C, and E. Let's check. So A, B, C, and E. Done. Let's do another one. All right, the nurse is providing pre-operative education for a Jewish client. Anytime you see a religious preference, it's important, otherwise it wouldn't be added. Scheduled to receive a Zenograft, there it is, right there, boom. To promote burn healing. Which information should the nurse provide this client? So there's a couple of things you need to know. You need to know an allograft versus a Zenograft. Versus an autograft. So an allograft is a tissue graft from a donor of the same species as the recipient, but not genetically identical. Now, that's important versus, even a homograft, now that I'm thinking about all the different ones. So a Zenograft is usually from an animal. And we can't confirm if it's quote unquote kosher based off of that. So this is why we would not give a Zenograft. So as I look down, I'm going to see something that has something to do with animals. So I'm waiting for it. As the burn heals, the graft permanently attaches. Well, okay, cool. Can you elaborate? What does that got to do with the breast tea in China? Grafts are later removed by debriding procedure. Yikes! What? No. Grafts are grafts. They stay on. Why would we debride and then kill more tissue? That's dumb. The Zenograft is taken from non-human sources. Yeah, we talked about that. Grafting increases the risk for bacterial infections. So no, it covers up the fear of bacterial infections because it creates that seal, right? That's the whole point of it. So these are just unsavory facts or non-factual comments or statements made about that are not true. Whereas a Zenograft is, taken from non-human sources, and why this is appropriate specifically to what we're talking about, which is the Jewish client. None of these have anything to do with those things, right? What does have to do with those things is the topic of discussion here. So one of these things is not like the other one. These things does not belong. Is definitely going to be the answer for this one. Also, one could say left, right, center, because we see Zenograft, and then we see. So hang on, we see Zenograft, and then we see non-human sources right there, left, right, center, and then center is taken from. All right, there's that. I'm sure there's other ones. Let's move to the next slide. All right, and just what we talked about, Zenograft is taken from non-human sources. That's the correct answer, and let's go to the next one. All right, the client is admitted with a severe asthma attack. And I see numbers out of the peripheral vision, so this is going to be about ABGs. And I'm going to tell you right now, asthma attacks fall into the box. Here's your box. And then we have respiratory. God, I need a pen so bad. Respiratory acidosis. This is on my list, guys. It's to the point where I'm annoyed. Respiratory alkalosis. I think what I'm going to do is I'm going to do a separate slideshow. Ugh, yeah. I'm going to do a separate slideshow for this. Respiratory acidosis, respiratory alkalosis, and then we got metabolic acidosis, and then metabolic alkalosis. So I'm going to explain this in a different slideshow. I think it needs to happen. I think we get enough ABG questions that we have to do it. So respiratory acidosis is always going to be asthma attack. I'll put AA for asthma attack, not Alcoholics Anonymous. All right, for the last 3 hours, the client has experienced increased shortness of breath. Whoop, shocker. Didn't even go there, knew it was coming. Arterial blood gases are 7.22. All right, so that's low. PaCO2 is 55, that's high. And first off, 7.35, 7.45 are your range here. And we got 3.5 to 4.5, literally same thing as the pH, just drop the decimal. And then HCO3 should be 22 to 26, and that's normal. So respiratory opposite at Rome. Before I start running my mouth about this, Rome. So I will teach you the box and I'll teach you Rome method because I'm most comfortable using Rome. So respiratory opposite, metabolic equal. This is low, this is high, that's opposite, so it's respiratory. And then we look at the pH and see that this is acidosis, so respiratory acidosis. So I'll teach you Rome, but I'll teach you the 4 boxes because the 4 boxes, notice that I went, as soon as I saw asthma attack, notice I knew this was going respiratory acidosis. Before I even looked down, I knew it was going respiratory acidosis. It's because of the 4 boxes method I teach. I teach a lot of rando hacks for a lot of rando things because I just see things differently. So if you get the 4 boxes, you're going to get the brunt of all these questions right just by seeing whatever disease process it is up at the top. I don't need numbers. I don't need to calculate things. It's important to know it for your patient, but for the purposes of getting through this examination and feeling comfortable about doing it, this is how we check our math, okay? So let's see what we got. Space care to provide periods of rest. All right, cool. Instruct the client to purse lip breathe. That's going to increase the shortness of breath by position client for maximum comfort. Administer PRN dose of albuterol. Duh, that's the answer. I'm like, where are we going with all this? Because technically I could argue for that point, but I don't like it. Space care to provide rest periods. It doesn't matter. They're in a severe asthma attack. They don't have time to rest. Purse lip breathing. We ain't got time for purse lip breathing because we're having status asthmaticus, so it's our throat that's closing. Again, nothing to do with breathing. Position client for maximum comfort. They're in an asthma attack. Why don't we give them some freaking albuterol and be done, right? So this goes through the idea of passive versus active. They're already in a position of comfort because that person's going through an asthma attack. They're already laying what's most comfortable, and they're still in attack. That's the scary thing. The only thing it's going to do in immediate action is albuterol. Plus, position, instruct, space care. This is actually doing something. So one of these things is not like the other one. These things does not belong. We can argue other points, I'm sure. So let's go to the next slide. And yeah, administer PRN dose of albuterol. That's our answer. So let's move to the next one. All right, so an unsuccessful resuscitation attempt. Bummer. Nurse calls the family of the deceased. The family wishes to see the body before it's taken to the funeral home. See the body before. Which intervention should the nurse take to prepare the body before the family enters the room? Select all that apply. All right, cool. Take out the dentures and place them in the label cup. No. All right, listen. Let's look at some things. So we're looking at this family before the family goes to the funeral home. So we don't want to see the family at the funeral home. At the funeral home, at that point, we've had our formaldehyde, we've had our embalming process. We're no longer us. We're just a shell. Versus a new body that is slightly warm still. It's like people think the bodies go cold in 5 minutes. They don't. Sometimes it takes hours. I'm not even playing. Sometimes it takes hours. It's a real thing. So they want that. They want to see that skin is still squishy and mushy and isn't like wax, right? You give me a person who's recently deceased. You give me hope in them still being human. You put them into the wax figurine. That's the Ripley's Believe It or Not, embalming process of the Egyptians. And you take their soul away somehow, if that makes sense. So I want you to think about these things because it's funny, people always say that people like me, we don't have emotions. A lot of people say that. But I need for you to know maybe my emotions are a little more powerful than what you would probably expect. So much so that that's probably why I don't say them out loud, because it creates fear in people. Because reality creates fear. But there's nothing to fear in reality because I'm not even sure that fear is real itself. Or sometimes reality for that matter, right? I mean, what does it all mean? Who knows? But what I do know is that we have to be respectful of people. And we have to put ourselves in their position in order to create a proper amount of respect and understanding, right? So let's keep moving. Let's see where we're at. Take out dentures and place in the label cup. It's a terrible idea. You're going to sink down the face. They're not going to be recognizable. In my last moments with my family member, I want them to be just as how I remember them before they become a wax figurine. I want them to know that they were at peace. All right. Apply a body shroud. No, that's not normal. It's not typical. A body shroud is something that we use when they're ready to go to the funeral home. It's what they have over them so that they are then carried across the hallway and nobody sees them. They call it a shroud. You guys have probably heard of the Shroud of Turin, which is what they believe was used when Jesus came down from the cross, right? So shrouds were pretty common back in the day, and that's what we use now just to, keep privacy. So we wouldn't do that at that time. That would be later. Place a small pillow under the head. Yeah, that's the thing. Here's why. If you lay down on a cheap hospital pillow with the weight of your head, it's going to smush the pillow down, and then it's going to sink your chin down and then open up your mouth. If you use a small, tight pillow, it slightly tilts your chin back and closes your jaw, even if I put you at an incline. Your sweet spot for an incline for a deceased patient, by the way, is 26 degrees. You can sit them at 26 degrees, their jaw still will not open, and if you have that small pillow and that jaw tilted back, it still looks like they're sitting up, and it doesn't look like they're hyperextended. So think about that. 26 degrees is your sweet spot. And are you really surprised that I know the answer to that? Do you know how I got to that answer? Of course you do. We all know. Because we all know what I am. And that's why you know, and you don't have to do the dirty work like I did. That's what I'm here for. I'm here to get all the answers so you can move on and learn new things. All right. Remove resuscitation equipment from the room. For the love of God, please do. Please do. Please get that crap out of there. Don't remind them of all the things in the tubes you had to put in them. Don't remind them of their last hours. Don't do it. Don't do it. Even if you got to throw it into a bathroom. Been there, done that, got the t-shirt. It's a size large. We're headed towards medium. I'm pretty excited. I'm just saying. So toss in there, close the curtain in the shower, shut the door, be done. No one's going to go in that bathroom given the circumstances. I promise you no one's going in that bathroom. It's not happening. No one goes in the bathroom where someone just died. People are terrified of it. I don't know why, but they're terrified of it. They'll walk out of the room. So toss it in there, move. All right. Gently close the eyes. Yes. Yes, you want to gently close the eyes. Why? Well, because remember, as we pass, we lose the ability to continue tears. So if you push them down, they stick like glue. I know that's weird. I know you don't want to hear that, but it's kind of real because it is. And sometimes if you push them down too jerkingly, in too much of a jerking fashion, it's going to do what the jaw does. Again, you have to do the jaw very gently, close it, hold it, count to like 10 Mississippi, and then slowly move your hand from the jaw. Same idea with the eyes. Only if you jar them, they're going to get indented from your little fingerprints. They might stick and then be halfway open. Or the eyelashes stick in between and then they like cross over one another. It does a milieu of bizarre things, but remember, you lose all musculature, so like things kind of go limp, and including in that limpness is your jaw and your eye sockets. So those eyelids are going to get wonky weird. So the best thing you can do is maintain its shape. I mean, they're not going to like turn into, liquid or anything, so it's not that scary. But you'll get it when you get in there and start feeling it. It gets squishy, icky, sticky. Also, if you have to turn them to the side for any reason, only do it once and make sure you have towels at the mouth. I'm not going to get too graphic, but do it. Chuck pads, do it. And you're only going to do it once. And after that, you will learn how to do it without turning someone to the side. But you're going to do it. You're going to do it on accident. And I'm going to teach you the bad lesson. And I'm going to make you learn what it is because I'm not even going to tell you. But I need for you to know you're only going to do it once. But make sure you have chuck pads. I will give you that nice little tip. All right, next slide. All right, so again, place a small pillow under the head. Got it. Remove resuscitation equipment from the room. Got it. Hide it. And then gently close the eyes. Perfect. Let's go to the next one. Back in Neuroland, where all the happiness stands. All right, cool. The nurse is preparing a client with an acoustic neuroma. All right, stop right there. Acoustic neuroma. First, neuro, brain. Oma, tumor. All right, so tumor of the brain. Acoustic. Tumor of the brain near the acoustic nerve. All right, cool. So basically, this is a non cancerous tumor. It's on the main nerve. It's leading from the inner ear to the brain. And it's called, it's an area of the vestibular schwanna or schwannoma is what it's called. It usually grows slowly. Sometimes it grows not at all. However, in a few cases, and when I say a few cases, I mean like 20,000 cases a year, all right? It may grow rapidly. It may become large enough to press against the brain and interfere with vital functions. Again, this is the bottom line nurse. We need to know that the bottom line nurse knows how to deal with the most rando things in the whole wide world, just to make sure that they're the bottom line nurse, right? She knows an acoustic neuroma means something bad's going to happen. Well, what's the bad thing going to happen? Well, let's think about it. Something around my brain is swelling so big that it's going to start popping things soon. What's that going to create? Facial numbness? No, it's not going to create facial numbness. I mean, I'm sure if it gets big enough, sure, but we're at the acoustic area. All right, so we got a little ways to go still. Right ear hearing loss. No, because this sits presumably in an oddly specific area, which could be neither left nor right. It could be global, right? Could be around the way, both sides. Or usually right ear hearing loss isn't what you get from an acoustic neuroma. That's not, I mean, kind of, but there's a bigger thing. Difficulty with balance, that's way on later on in the gate. But what you get in the very beginning, because this is all way later in the game, you get intensifying headaches the first thing that you complain about. And it's always in the same spot. Always. And it never goes away. All right? So that's acoustic neuromas for you. Kind of a mess. It is life-threatening for sure. But that's your answer. 100%, 150%. Because all these are later symptoms. And then eventually it gets really, really bad. So let's see. Next slide. All right, cool. Just as we thought, so we'll move on to the next one. All right, when caring for a client with full thickness burns, yikes, stop right there. All right, full thickness burns. Here's what I need for you to know in the land of NCLEX and exit Hesi and standardized testing in the world of nursing and medicine related to full thickness burns. Full thickness burns, you're always going to come up with the following. Compartment syndrome. Write it down. It's always going to come up. Full thickness burn. Hypovolemic shock. It's always going to come up. Percentage of burn. Always going to come up. Always, always, always. Maintaining pulses. Always going to be a thing. Immediate risk for infection. Always going to be a thing. Inhalation burn and hoarseness in the voice, always going to be a thing. If you focus on those areas in burns, that's going to be the brunt of the things you need to know in burns. I'm sure there's more, but off of my head, these are the ones that I can think about most commonly thrown through. Did I say compartmental syndrome? Yes. Circumferential compartmental syndrome is the worst of the abdomen. That'll kill you quickest. And a fasciotomy is what we do to get rid of that. It's a bedside fasciotomy. It's where we slice and dice and just get things to split open and let it settle so that we can move that diaphragm. All right, so now that I've not even looked beyond the sentence, let's see what we got. Which assessment findings warrant immediate intervention by the nurse? Weeping and serous fluid, firm wounds. No, that's what happens when you have a full thickness burn. Slothing tissue around the wound edges. No, that's what it's going to do because it's a full thickness burn. Change in the quality of peripheral pulses. Haha, remember compartmental syndrome. There's our example right there. Change also because of hypovolemia. Right, we're losing all of these fluids. Loss of sensation to left lower extremity. Yeah, again. Compartmental. We're squeezing and then we're losing sensation from the inside, and then our pulsers are going crappy. Complaint of increased pain and pressure. It's a full thickness burn. I'm pretty sure you're getting both of those because of the inflammatory mediators that are going on, all of the fighters that are happening right now, all of the fluid loss. Your body's in panic mode. It is going stupid. So yeah, I'm going to say C, D, and E final answer, and let's look. All right, C, D, and E is the answer. I'm going to go ahead and upload these, and then I'm just going to keep doing them bits of 10 at a time. They all turn out to be like 40 minutes or an hour, and I feel like that's enough. And then you can take a brain break. And don't forget the 7 principles video so that you can look back at these and use it to answer these questions with me. All right. I love you guys and proud of you. It's going to be great. Bye.